So Jurgita will introduce the next speaker.
So hello again, everyone, and we are moving from one difficult topic to another, and talking about suicide and psychosis. This was again one of the questions raised in many of the feedback forms after our earlier conferences, and it is a very challenging situation when severe mental illness and suicidality intersect. And I'm very happy to introduce our next speaker speaking about this, Professor Patricia Gooding. She leads the suicide research group at the University of Manchester, and her work focuses on understanding and preventing suicidal thoughts and behaviors in vulnerable groups, including those with severe mental illness. The research group led by Professor Patricia Gooding is specifically investigating the mechanisms underlying suicidal thoughts and behaviors among these vulnerable people. And she has led a large trial investigating psychological interventions for suicide applied to patients with psychosis. So I do believe you are the best person to talk not only about research, but how to actually implement it and how to actually help these people in such difficult situations. So thank you for being here with us today, and welcome.
Thank you very much indeed. So can I just check, you can hear me okay?
Yes.
Okay, lovely. So thank you for that glorious introduction. It's great to be here. Good morning, everybody. Now, shall I try and share my screen? That would be helpful, wouldn't it? Okay. So I'm now sharing my screen. I will now present from the beginning, just using PowerPoint. So let's just see if that's working. Okay, so hopefully you can all see that. That's the first slide. Can I just check that that's correct? Okay, thank you very much indeed. So indeed, yes, I work with colleagues at the University of Manchester, trying to understand the psychological mechanisms which underpin suicidal experiences. And perhaps before I begin, I should just say that I am actually an expert by experience. So I'm someone who has had kind of direct experience of suicidal thoughts and feelings, and that helps. Okay. So what I'd like to kind of go through today, I'll talk to you a little bit about psychological models of suicide. I'll tell you a little bit about the CALMS project, that's Cognitive Approaches to Combating Suicidality. That's been going now, we started it in 2017. We had a bit of a break because of COVID, and we're just winding it up really, we're just finishing it now. So I'll tell you a little bit about that. I'll talk to you a tiny bit about psychological resilience to suicide, and then perhaps just reflect on some clinical implications. Before I do any of that, I would just like us all to think a little bit though about what we mean by suicidal experiences. Often in the literature, in the academic literature, we read predominantly about thoughts, plans, attempts and deaths. And yet when we talk to people, we find that things are not really so kind of finely tuned. So people will say things like, yes, I do have thoughts, but I don't really know what a thought is compared to, just a kind of a feeling really. Some people will say, is it a desire? Is it an intention? I have urges, I have compulsions. So I think one of the things for me that's kind of really important is to be aware that suicidal experiences can be really very diverse. They can manifest in different ways, and they're not necessarily something that people can immediately tune into. So people, quite often will sort of say suicidal experiences, oh, it's not that bad at all. But then when you probe, you find that actually people have been having or living with suicidal experiences. So I just wanted to put that up, just to kind of get us thinking really about the language that we use when we talk to people about their suicidal experiences. Okay, so one of the things that we've been trying to do for quite some time really is to develop suicide-focused psychological therapies. So those psychological therapies being grounded in CBT, so cognitive behavioural therapy kind of approaches. And our starting point for developing suicide-focused therapies is that they must be built on evidence. There should be an evidence-based model or evidence-based models which guide the way in which we think about suicidal experience. Now, or experiences. What I often say is if you don't have an evidence-based model of kind of suicidal experiences to start off with, then when you're starting to think therapeutically, you might as well be practicing witchcraft. And that's not okay. So let's look a little bit at some of the psychological models of suicide, which are, I suppose, the most recent ones, perhaps. Now, the cry of pain model by Mark Williams, this model was, it's been very much influential in the work that we've been doing at Manchester. I'll say more about that in a minute. We have the interpersonal theory of suicide by Thomas Joyner and colleagues, the three-step model of suicide, the integrated motivational volitional model of suicide, and the schematic appraisals model of suicide. Now, this is a model that we have developed, and it's a model that we've been kind of using, I guess, again, since around about 2008 was when we first started to think about it and develop it. I will say that more about that in a minute. But let's just look at the cry of pain model of suicide by Mark Williams and colleagues. Now, this is very much our rendition of this model. And the way that we've sort of carved up, or the way that we try to understand the cry of pain model of suicide, is that suicidal experiences, indeed, as Mark Williams put forward, needs to be thought of not really as a cry for help, which can often be dismissed, but a cry of pain. And the question is, what is going into that cry of pain? What is happening from a psychological perspective? Now, a starting point, of course, is that people experience internal and external negative stresses. And it's not just that the stresses exist, but it's people's appraisals of those stresses. And perhaps what's important for severe mental health problems is thinking that those problems in themselves are stresses. So we can think about external stresses such as, I don't know, finance or problems with money or losing your job or a relationship breaking up. But then on top of that, if you're experiencing mental health problems, including things like, for example, extreme anxiety, that in itself is a stressor. Now, the model goes on to say that there will be that we need to consider negative cognitive biases or information processing biases and suicide schema, that there are different ways of appraising yourself and your situation, which can perhaps be can be summarized as negative appraisals of the self, other people, and your living conditions, your living environments. Perceptions are again appraisals of feeling defeated, trapped and hopeless. Now those three kinds of perceptions crop up a lot in just about, not quite all the models of suicide, but in many of them. That you have a perceived absence of rescue factors, so there's no way out. And that's of course very much linked to feelings and perceptions of entrapment. And of course that you have an availability of imitation models of suicide and methods of suicide. So that cry of pain model is a model that very much has fed into the way that we think about suicidal experiences and what's happening with suicidal experiences for people when they're also living with severe mental health problems. So this is the schematic appraisals model of suicide that we published in 2008. And you can see there that we've got cognitive processing biases, we've kept that, suicide schema, which I'm not going to say too much about because it's kind of hard, and appraisals. So focusing on different kinds of appraisals, of course, there are many different kinds of appraisals, but from the literature, the appraisals which we have honed in on, which we've focused upon, you can see there that we've got perceptions, of course, of defeat, entrapment and hopelessness. But based on the literature and based on working with people with severe mental health problems, what has hit us, what's come across to us, is that appraisals of poor social support, and I'll say certainly more about this as we go through, poor social support, but also poor connections, not feeling connected, that plays a key part in pathways to suicide. Feeling that, so again, appraisals that your problem solving abilities are quite poor. And again, that's not just any problem solving ability, but although it can be certainly, but problem solving when it comes to kind of interpersonal relationships. And oftentimes people kind of explain that for them their problems just seem overwhelming, just too big, and they don't know where to begin with kind of even approaching those sorts of problems, and different kinds of emotional difficulties. So just to kind of put this in a little bit more, or give it a little bit more kind of life, I guess, let's just see, if we look, here you've got suicidal thoughts and acts in the centre, and then you've got these different sorts of appraisals going around, so feeling trapped, hopeless, having emotional difficulties. Let's just see the sorts of things that people have sort of said. So things like, it's relentless, I can't see a way out, it's very much reflecting feeling trapped. Yeah, I feel hopeless every day. I can't reach my emotions, so I can't find my emotions. They're buried. Life's defeated me. That's what it is. Yeah, right. I've been defeated. Well, I feel like an outcast. It's like, if I kill myself, who's going to miss me? I've given you perhaps a little bit of a kind of a feel, I hope, when we talk about appraisals. I hope I've given you a little bit of a feel of what people actually say. Now, the evidence for the schematic appraisals model of suicide is kind of, it is transdiagnostic. So the model itself is transdiagnostic, so it shouldn't really matter what kind of diagnosis people come along with, in terms of their suicidal experiences. But it's also mental health problem specific. And to date, we've done work with people who experience psychosis, PTSD, bipolar disorder, I don't like the word disorder, so we'll just keep that as bipolar, and depression. Now, before I tell you about some of the work that we've been doing with people who experience psychosis, I guess one thing to really kind of underscore, and this is again work that's been done at Manchester by Nav Kapoor and his kind of teams, is that rates of death by suicide are high in individuals with mental health problems. So in kind of the period over which the National Confidential Inquiry, which looks at death by suicide and also the extent to which individuals who died by suicide were in contact with mental health services, so NHS mental health services. People who have severe mental health problems, they comprise 26% of all suicide deaths. And if you look at the three-dimensional pie chart just to the right of your screen there, you can see that the biggest proportion there was people with affective disorders. So that includes things like depression, it includes bipolar. Then we have schizophrenia and other delusional disorders taking up 15% of that kind of pie chart. So really I've just put this here to kind of underscore that suicide deaths are kind of really very much elevated in people with mental health problems. But as I kind of started off with right at the very beginning, it isn't just deaths that we need to be thinking about, it's all kinds of suicidal experiences. And of course, suicidal thoughts, plans, urges, compulsions, presences, they are also very, very much elevated in people who live with severe mental health problems. Okay, so just to kind of make that a little bit more concrete, if we think about people with non-affective psychosis, suicide death is frequent, so 8 to 10% of those individuals die by suicide. 20 to 40% will attempt suicide during their lifetime and or have ongoing thoughts of suicide and self-harm. Okay, so let me just start off by telling you a little bit, or just a bit before I kind of start to tell you about the Calms project. Let me try to set the scene a tiny bit for a suicide-focused psychological talking therapy. What does that look like? Well, I said that it had to be based on mechanisms, so we'll come to specific mechanisms in a minute. But let's just think about, what does this talking therapy, this CBT therapy, look like? Now, the acronym for it is CBSP, which I don't particularly like, so I can never remember it, believe it or not. But anyway, Cognitive Behavioural Suicide Prevention, Cognitive Behavioural Suicide Prevention for Psychosis. So CBSP and CBSPP. Now, we have got a treatment manual. We developed that with Nick Tarrier, again, way back 2008 is when we first started developing this work. We've since trialled it. We've trialled it on inpatient psychiatric wards. We've trialled it in prison settings. And of course, we've trialled it in the community. What does something like this look like? Well, the therapy itself is very much grounded in kind of humanism, in kind of Rogerian principles, but also the sorts of kind of principles and foundations that you'd expect in any kind of cognitive behavioural therapy. So, the therapy itself, of course, it's highly collaborative. Even though we will be thinking about mechanisms and what's going on, how we can unpick what's going on when somebody says that they have got suicidal experiences, even though we'll be thinking about mechanisms and we'll be thinking about the kind of psychological processes which are underpinning all those thoughts and feelings, the way that we work with people is highly collaborative and it's formulation driven. So in other words, what we're trying to do is map out what is happening for that individual, but working with that individual. So trying to be the opposite of being impositional, not imposing what our views are, but genuinely working collaboratively with individuals. The sort of work that we've done to date tends to be one-to-one, and indeed the meta-analysis that we first got published way back in 2008, one of the findings that kind of brought up, one of the things that showed, was that cognitive behavioural therapies indeed at that time highly promising. But there were a couple of caveats. One was that the evidence was not so good for people who were called adolescents. Again, that's a term I don't particularly like, but I'll use it anyway. The other is that CBT therapies tended to be stronger, the evidence tended to be stronger if you worked in one-to-one settings versus in groups. So as I said, the pilot work that we've done with our suicide-focused therapy, we first trialled it with people living with psychosis in the community, people incarcerated in a prison for men, and people on psychiatric inpatient wards. Okay. And most recently, we have been able to trial, we've been able to kind of go a little bit beyond a kind of a pilot or pilot work, and run, I suppose, a medium-sized RCT or project, which we call CALMS, Cognitive Approaches to Combating Suicidality. So let me try to give you a feel for that. So this work was funded by the Efficacy and Mechanism Evaluation Programme in the UK, which was a collaboration at the time between the MRC, the Medical Research Council, and NIHR, so the National Institute for Health Research. And so we were able, the clue is in the title, Efficacy and Mechanism Evaluation Programme, we were able to test efficacy, and we tested that with a pretty standard RCT, but we were also able to look at mechanisms which we tested with, for example, mediation type modelling. So bringing both of those together, I guess, was the sort of fundamentals of the CALMS project. However, one really kind of strong aspect of the CALMS project was that we had interwoven with the RCT, we had interwoven 4 qualitative work streams, which are really important because they gave us information about the practical aspects of running a trial and the practical aspects of trying to deliver a suicide-focused therapy, but also they gave us very, very important information about underlying psychological mechanisms. Now, I should say, I sort of said at the beginning that I am an expert by experience. So, of course, we had experts by experience, so people with lived experience of suicide and severe mental health problems in every stage of the CALMS project. They were self-named the Calmers, that's what they called themselves. So they even, as you might expect, We were told that we had the funding, that we'd been successful in 2016, and that we could start the CALMS project in 2017, January 2017. But of course, the CALMers were completely instrumental in us even getting that funding, and had started working with us, sort of way back in sort of 2006, 2007. And when we were putting together the grant application to get the money, to get the funding, and we sort of started to put that in, believe it or not, in 2014, then they were very much instrumental in us just getting that funding in the first place. So let's just have a look at the CALMS project, and particularly the kind of trial part of it. So as I said, we tested efficacy of a suicide-focused therapy. We tested underlying mechanisms, and we attempted to determine the challenges, the kind of barriers and the facilitators of the extent to which our therapy could be implemented in services. We had 3 time points: baseline, after 6 months, and after 12 months. Why did we choose those time points? We offered individuals 24 sessions of therapy. Those therapy sessions were usually, not always, but they were usually delivered once per week. So that equates to 6 months of therapy. So we did our assessments right at the beginning, then when therapy finished, and then at 12 months. For the trial, that 6-month time point was absolutely critical. Now, as I sort of said to you, testing the underlying mechanisms, we used kind of quantitative data, we used trial data, we used mediation modelling, but we also tried to use qualitative data to see what was going on. Okay, let me just check the time. So just to sort of look at the kind of inclusion criteria, I guess, for participants in the CALMS project, everyone had to be adult, so aged 18 or over. They had to have sufficient English to be able to complete the assessments, but perhaps more importantly, they had to have sufficient English to be able to engage in therapy without an interpreter. They needed to have experiences of psychosis, and that in particular was what a psychiatrist would call positive psychotic experiences. So hearing things that other people don't hear, seeing things that other people don't hear, sometimes tasting things or sensing things, or feeling things, feeling somebody's, or feeling that you're being touched, but there's kind of nobody there. Perhaps feeling a little bit quite a lot of mistrust, a little bit suspicious, perhaps a little bit paranoid. Those are the sorts of psychotic or positive psychotic symptoms or psychotic experiences that we were interested in. We asked that participants had recent suicidal experiences, and that was in the 3 months prior to recruitment. It's quite unusual to find trials which recruit individuals, if you like, who are acutely suicidal. So we were able to do that. And last but not least, all of our participants had to be under the care of NHS mental health services. So they needed to have a care coordinator. That care coordinator could indeed be their care coordinator, called that, their care coordinator. It could also be their GP or their psychiatrist. That didn't happen so often, I have to say. Most of our participants had designated care coordinators in mental health services. The design of the CALMS RCT component was in fact kind of very, very simple. It just had 2 arms or 2 conditions. So participants were randomly assigned either to receive the treatment, so to receive the suicide-focused therapy, CBSPP, in addition to treatment as usual, or participants were not offered any kind of active treatment. They just carried on with their usual treatment. What we were trying to see was the extent to which our treatment, our suicide-focused therapy, the extent to which that would reduce the severity of suicidal ideation or suicidal thoughts over 6 months. And the measure that we used was the Adult Suicidal Ideation Questionnaire. So this shows you the participant flow through the actual trial. We were wanting to recruit 250 people, and we managed to recruit 292. We ended up with 252 at the critical time point, which was 6 months. Okay, so you can see that to the left, that at 6 months we ended up, our sample size was 252. When we first started the trial, when we first started CALMS, of course, as you might imagine, one of our key anxieties, I guess, was that we just would not be able to recruit people into the trial. So we were delighted actually that we were able to recruit people and that our retention levels were such that we were able to retain individuals. So we retained 86% of people at that 6 months time point. Now, I kind of said right at the beginning that it was important when we're thinking about models, when we're thinking about mechanisms, when we're thinking about pathways, to think about transdiagnostic aspects of what's going on when somebody becomes suicidal, but also to be kind of thinking, I guess, about mental health problem specific aspects of what's happening. So I just wanted to turn to that just for a minute and just to think about what kinds of experiences people have when they're living with kind of delusions and hallucinations. So these are just some of the things that people have said. Everyone was against me. I do get feelings that everyone is against me. The whole world hates me. I had this idea that there was cameras and microphones everywhere, where I spent a year thinking people were out to get me and that people were wanting to hurt me. Then, but if you can imagine taking your brain out and putting a little person and they shout, I've experienced that. I don't like that because that's very invasive. I don't know, I've got no control over it. It's all the voices feel so real. So for many individuals, they had very, very strong thoughts and feelings that indeed the world was out to get them. For some people that they were kind of doing things, they were engaged in activities which was harmful to other people, that they couldn't really, there was no evidence for it, but they were convinced that they were doing things. So I remember one individual who was, that they had a kind of a cafe that they'd recently set up, and they were quite convinced that the food that they were making, the food that they were selling in the cafe, that was poisoning everybody. There was no evidence, nobody was getting ill, they were not poisoning everyone, but they thought that they were. Okay, similarly for hallucinations, for a lot of people, the hallucinations and the voices that they're hearing, they're there from when they wake up in the morning all the way through, not only to when people go to sleep, but during the night as well. So it feels as though those voices, that you cannot get rid of them, and they're nasty, critical, kind of horrible voices. For many individuals, it's not just voices or images, so they will hear things, they will hear voices, but they will also see things, and sometimes what they see is not necessarily an image, it's kind of a scuttling under the sort of skirting boards. There's something there, but I can't quite get hold of it, that kind of feeling. So I've kind of said, I've tried to give you a little bit of a feel of the impact, I guess, of living with delusions and auditory hallucinations. And so one of the things that we wanted to do with baseline data is get some idea of what's going on then, not necessarily with the severity of delusions and auditory hallucinations, but something else. And this is something that my colleague Jill Haddock has been sort of working on for some time, which is looking at kind of what it's like, what's the key thing about living with delusions and auditory hallucinations. And of course, one of those things is the distress that people feel. So it's not necessarily severity, it's not necessarily frequency, it's not necessarily how loud those voices are, but it's the internal stress that people feel. So we wanted to start with that and sort of say, if we look at the frequency of suicide attempts, what's going on in terms of a pathway? And so we found that distress from delusions and auditory hallucinations, that was indeed a starting point. That fed into what we've called emotional processing difficulties, and which I'll say a little bit about in a minute. Now that led to, so that path from distress to emotional processing difficulties led to suicidal ideation severity and suicide attempt frequency via perceptions or appraisals of defeat, entrapment and hopelessness. That pathway, so hopelessness could act as a mediator, but it also acted as a moderator, in that it moderated that pathway between defeat and entrapment to suicidal ideation, such that that pathway was operating, the stronger was your feelings of hopelessness. We also found an interaction effect or a direct effect whereby distress from delusions and auditory hallucinations, emotional processing difficulties and hopelessness, they kind of added up to impact on suicide attempt frequency. And suicide attempt frequency was the highest when distress, emotional difficulties and hopelessness were also high. Now this is kind of quite, being able to do this kind of work in many ways is quite rare, because it's not that often that you have people where you can look at their suicide attempt frequency, and that was frequency over 8 months, along with the severity of suicide thoughts. Now, I said there quite vaguely, really, emotion processing difficulties. Let's just look at the kinds of emotional processing difficulties that we mean. So we've got things like confusion about emotions. So I have difficulty making sense of my feelings. Non-acceptance of emotions. When I'm upset, I feel guilty for feeling that way. Limited access to strategies, if you like, for dealing with intense or uncomfortable emotions. When I'm upset, it takes me a long time to feel better. Okay, so let me tell you now about what we actually found in the RCT, especially over 6 months. This was recently published in Lancet Psychiatry about a year ago now, January 2025. So I said that the key time point was 6 months, and you can see there that suicidal ideation severity, that's the green line as you look at that, suicidal ideation severity does indeed decrease over 6 months. And although it decreases in both groups, which you might expect just from things like regression to the mean, the rate of decrease was more accelerated in people who had received our suicide-focused treatment compared to the control group. However, what must be pointed out is that although there was a decrease, and although there was a difference between those two groups, the size of that difference didn't quite reach a level of traditional significance. So the traditional level of significance is 0.5. This was getting there, the probability was 0.07, but just not quite there. So that, of course, leads you to sort of think, well, what was going on? For people where the therapy was making a difference, what was the key thing? What was the most important thing? Can we identify that? So I'll try to say a little bit more about that. Now, I said that I kind of tried to outline 6 different kinds of appraisal mechanisms which we thought would be particularly important for suicidal ideation severity. And indeed, all those appraisals, those 6 different types of appraisals, were important, and they were all associated with suicidal ideation severity at 6 months, whilst controlling for baseline. So just to go through those again: defeat, entrapment and hopelessness perceptions, and appraisals of poor social support or poor social connectivity, emotional difficulties and problem-solving difficulties. So the question is, would there be any one of those different kinds of appraisals that might be more important when thinking about a treatment effect, when thinking about why this treatment might have a kind of positive effect? And what we found when we did our kind of mediation analysis, and this indeed was significant, that if we look at the 2 groups, the treatment allocation condition, and we look at the outcome, so a reduction in suicidal thoughts or through suicidal thought severity at 6 months, the main kind of appraisals that were important were perceptions of social support, and that was by friends, family and other people. So although there wasn't a direct effect, there was a mediated effect. Okay, so if you look at why the therapy was working, and if you put social support in there and say, well, was it because of that? That was a sort of a prediction, a concrete prediction. Was it because of social support? The answer was, yes, it was. And the sorts of, the measure that we used, which was a social support appraisal scale, what that picked up on was things like, I'm loved dearly by my family, I can rely on my friends, but also something which was a little bit more kind of general, which was, I feel valued by other people. So not necessarily friends or family, not specific people, but just in general, I feel valued. Now, this is important because we'll kind of go on to kind of build on that, I guess, with some of the qualitative work, which I'll tell you about in just a minute. Now, Jill Haddock, who I work with, she was one of the co-principal investigators on CALM. She said to me, okay, Trish, but this influence of social support that's coming in here, this effective social support, is it not just because of the therapeutic alliance that our participants in the therapy condition, they just had a really nice, a really good relationship with their therapist? So we tried to kind of test that a little bit to see whether or not a measure of the working alliance, or the bond that individuals had with their therapist, did that make any kind of difference? So we looked at the difference in social support, and we looked at the difference in suicidal thought severity, and asked, does working alliance, if we look at measures of working alliance right at the end of therapy when people have finished, does that make any kind of a difference? Well, it does, but kind of. So we found that the therapist ratings of the working alliance might be playing a role, which I will qualify in a minute. However, the way in which the working alliance measures, or the working alliance ratings of the therapist, the way that had an influence was not on social support from friends or family, but it was more general. So people, for example, feeling I'm not important to others, so that kind of changing, and changing from a feeling that you don't belong to feeling, well, yes, I do belong, so I feel like I belong. However, I must qualify this by saying that in order to kind of find that kind of effect there, we had to reduce our p-value to 0.1, so we used confidence intervals of 90%. We did have measures, yes, we did indeed, of course, have measures of the therapeutic alliance, but we only had data points for 67 participants out of around about 250. 125, and that was because we needed to have data points for social support, for the alliance, and for suicidal ideation severity at baseline and 6 months. All of those three things had to be aligned, and that was only aligned on really quite a small kind of subsample, I guess, of our total sample. The variance that this accounted for was again quite small, only 4 to 9%. And the effect that we found was for therapists' ratings of the therapeutic alliance and not clients. So that, of course, leads you to say, well, what is going on? In order to get more of an idea of this, we did a kind of a cluster analysis to see, well, what items of the measure that we used, what sort of clustered together. Now, this is work that is not yet published. It has been submitted for publication. And what we found, what clustered together, was people sort of saying, people's perceptions, that they're not important to others, kind of in general, that their family could not rely on them, but also that they could not rely on their family, and that their family didn't care about them. Those were the aspects of social support or social connection that came through with the questionnaire measure that we used in the RCT. Now, I said that the work that we'd done with, that was kind of qualitative work, so it's one-to-one qualitative interviews, that this could perhaps tell us a little bit about the mechanisms that were underlying suicidal experiences. And also, I guess, not just when things were going wrong, but kind of transitions, or what starts to happen, what is happening when people move from feeling suicidal to not feeling quite as suicidal anymore. And again, I'm just going to try to give you a little bit of a flavour of that with our qualitative work. So we found three overarching themes when we interviewed people, and what we said was, can you just tell us, when you're suicidal, what's happening? What's going on for you? Can you tell us? Now, what I'd like to focus on is what you can see on the left-hand side of this screen. And that was a dynamic, or if you like, a scale, between people feeling that they mattered to people feeling that they didn't matter. And this is a term or a concept that has been highlighted by Gordon Flett and his colleagues quite some time back now, and working more with young people and finding that, of all the things that you can look at, this idea that you matter, or indeed that you don't matter, seem to feature very, very strongly in poor mental health. And then if we look at what we have in kind of pink, just underneath the main themes, we have, again, a balance, a dynamic, a tension, if you like, between people feeling that they are utterly inconsequential to them having some kind of meaning, to people feeling that they're an unvalued burden on society, on their family, on society, versus having a role that they feel more acknowledged. So let's try to unpick that a little bit. So to give you an idea, this is that we didn't use these items, but it kind of gives a flavour of what we mean by mattering and indeed anti-mattering. So in terms of mattering, things like people don't ignore me. Often people trust me with things that are important to them. There are people who react to what happens to me in the same way that they would do if it happened to them. Sometimes I feel almost as if I were invisible, that sense of invisibility. People do not care what happens to me, so that goes back to my family doesn't kind of care about me. When I have a problem, people usually don't want to hear about it. So let's again then have a look at some direct quotes just to get a feel for what people were saying, with the focus, I guess, on transitions. So this is something that somebody said. One of the main things that was around killing myself, it's like, if I kill myself, who's going to miss me? Who's it going to affect? And the more you think about that, actually, I've got my mum, my dad, I've got my sister, I've got the animals, I've got all the people that I've met, all the people I've spoken to, all the people I've made a decent impact on. They don't really know me, but I've helped their life. And it's massive when you think about it like that, I think, indeed. This is a depiction of a broader sense of transition, so a future that holds promise. Well, my outlook on death has changed. I've always said that if I died tomorrow, I'd be happy because I've done enough in my life and, you know, I've got no regrets. But since the engagement, I don't want to die now. I want to grow old with, and they were talking about their partner. So it's funny how just a commitment has totally changed my outlook on my future. If my time came, then that would be it, and I wouldn't bother. But now, so like if I got cancer, for example, it wouldn't scare me. Death wouldn't have scared me. But if I got cancer now, then I don't want to live without, that's their partner, you know? I want a future with him. Life's just starting again for me. So you can see quite a profound change there. So building on that a little bit, I just want to kind of highlight, I guess, some of the work that we've been doing on resilience to suicide, psychological resilience to suicide. And perhaps what I should do here is also draw a link, or make a link between resilience to suicide and the schematic appraisals model of suicide. So when we first developed that, we weren't just thinking about the psychological pathways underlying suicide. We were thinking about, well, what goes on when people show resilience to suicide? And you may think, well, are people resilient to suicide? Does that happen? Well, if you work with people and you say, if you use the word resilience, quite often people sort of say, oh, I'm not resilient at all. And then you say to them something like, okay, so you're telling me that you're not resilient, but you're here. You're sitting in front of me, you're opposite me now, so how come you are here then? You know, what's gone on? And then they'll think a bit and they'll kind of go, right, okay, yeah, you're right, I am resilient. And this was work by somebody called Natalie Berry, and she did this work as part of her training to become a clinical psychologist. And if we just look, we've got 4 overarching themes, I suppose, coming through in the kind of the darker blue. And if we start with a sense of control and then go to a sense of hope, a sense of self-worth and acceptance of suicidal thoughts, there's 2 things I think that I'd like to kind of focus on here. First was a sense of control, and second, the acceptance of suicidal thoughts. Now, with people experiencing hallucinations particularly, but also delusions, that sense that they've got that feeling of living with hallucinations. They are powerful and persistent voices. They won't go away. There's an overwhelming kind of feeling that you just don't know what to do. You're overwhelmed by what's going on. You're overwhelmed by your own emotions. You can't make sense of them. Now, what came through there was not so much that you can control those voices, but that they can't control you. So it's not that you can make them go away. It's that those voices are just the voices. They are voices. You do not have to do what they say. Okay, it's not that they're going to get any nicer. It's not that they're going to get any less frequent, although sometimes they can do that, especially if you sort of say they can't control me, I'm not going to focus on them. So it's not that any of those things are going to happen, that they're going to get less frequent or less severe. The key thing is that they're not going to control you. And similarly with a sense of kind of acceptance of suicidal thoughts. Now, acceptance often seems very passive, and many of our participants have said it's not passive. And it's very similar to what I just said about not allowing thoughts, feelings, voices to kind of hijack you. It's being able to live alongside what's going on. And what some people sort of said is it's stopping the battle. It's realizing that you don't have to fight anymore. You can just put things down and let them be and carry on with other aspects of your life. So I've just sort of underscored here a little bit some of the things that kind of help, some of the things that kind of people sort of said. So I understood things a bit more. I found it got easier. I found it got easier to sort of understand how I felt. And for this individual, they also realised that it was okay to feel a certain way and that they shouldn't feel bad about not being okay. He, the therapist, helped me to understand some of my behaviours, like when I took that overdose, and that emanated in, for this individual, feeling that they could forgive themselves a little bit, that they felt a little bit more confident that they could keep going. For this third individual, I've got to appreciate myself as I am. Keep things simple, try not to do too much. So for this person, they were caught between massive ambitions, so wanting to be somebody, wanting to always kind of achieve, or wanting to always kind of look amazing in other people's eyes. And for them, they had a realization that just being themselves, that was more important than being somebody who's seen as someone who's accomplished a lot. Now again, here we've got someone who sort of says, I'm going to be like this for a while. And so instead of trying to fight it, so this is this idea of accepting, of not having to fight all the time. So this person is trying to get across that you don't have to fight it all the time. There's no point in trying to battle it. And so what they sort of felt was just do whatever makes you happy. So if I was happy just lying there on the settee, for instance, playing games or something, then that's fine. There's no point in not doing that. So to try and summarise that a little bit in terms of kind of clinical implications, the things that we need to understand. Right at the top there, I've kind of got interactions between distress. And clearly what I'm focusing on here is distress from psychotic experiences, so from delusions, hallucinations, but it's not just delusions and hallucinations. I don't know if any of you have worked with people, for example, with severe anxiety. I've got a good friend who at the moment is going through really, really bad anxiety, and the distress that individual feels on a daily basis is quite phenomenal. So what's important, I think, in looking at mechanisms and try to understand what's going on in order to build an effective kind of a suicide-focused psychological intervention is understanding what's happening with distress from mental health problems and transdiagnostic psychological processes. Linked to that, it's understanding what's happening with different manifestations of entrapment. So not just feeling trapped, but trying to work out what to do when you feel that what you're going through is relentless and that you feel overwhelmed. Trying to get a handle on different kinds of emotional difficulties, and what came through for us was things like not being able to accept emotions, feeling emotional confusion, which is not surprising when you feel that your emotions are you're overwhelming, and not feeling that you've got kind of any strategies. What do you do when emotions are too intense or they feel too intense? If I just skip resilience for a minute. How to, as we saw with some of those kind of quotes, how to scaffold transitions. And it's in transitions that are important, from antimattering, disconnecting, feeling a sense of disconnection, feeling discounted and invisible, feeling that you don't have a role, looking out for those kind of transitions. And also to understand that transitions come and go. So it's not necessarily that one day, if you feel that there's a transition from feeling disconnected to feeling more connected, that the next day it'll be like that. And the next day it'll be even better. It's not like that. Things go up and down. And sometimes just labeling that and sort of saying, perhaps if you expect that things are going to go up and down, that for many people, that's a massive source of kind of reassurance. Many people, especially with psychosis, came to us saying that they felt ununderstandable. And small things can show that family and friends do understand, and more importantly, that they want to understand. Another aspect of feeling connected that came through to us was that connections are not just social. So as we saw in one of those earlier quotes, people can feel that they've got a connection with animals, with places, with buildings, with ancestors, and with nature. And trying to ask people about those different sorts of connections can be really important. Again, something that's kind of come home to me that's been underscored in some recent work that I've been doing is this idea of feeling a connection with ancestors, and not just with sort of grandmother, your grandmother, or your great-grandmother, your grandfather, your great-grandfather, but going back through generations and generations and generations, and feeling a kind of connection with what was going on kind of for you, with your tribe kind of thing, generations and generations and generations ago, and that is important to you. And if I can come back to kind of resilience here, to perhaps have at the core that people are resilient, they're fantastically resilient. To my mind, people with mental health problems are some of the most resilient individuals that I've ever come across. So a need to understand and bring to the fore the kinds of dynamics, so that the kinds of dynamic resilience that people can and do develop, for me, that is crucial. Okay, and just finally, I just want to acknowledge, okay, I'm describing here work that's happened in Manchester. There's loads of people who've made this work happen. Those are really, really important people, perhaps the most important being that the participants have worked with us and shared with us their insight. Our calmers, our experts by experience, people who've helped us by kind of chairing committees to make any of this work happen. Our therapists, so in the Calms project, we had 12 therapists, believe it or not. Our Calms kind of researchers, and many, many of our colleagues working with NHS mental health services. Okay, thank you all very much indeed. I'll stop this and open to questions. Let's just stop sharing. Okay, thank you.
Thank you very much for this very informative presentation, and I just want to say that it's an impressive trial and an impressive retention of patients in the trial, given the difficulty of their diagnosis and experiences. So thank you for sharing this with us. And we have several questions, and they are related to the specifics of approaching people who have these psychotic experiences and are suicidal. And I wondered if initially you could give, I don't know, if a clinician was going to go see a patient today who is likely suicidal and also has psychotic experiences, what would your top 5 tips would be for this person?
Okay, so I think there's really one major tip, which is completely central, which is to ask straight out. So if you have any kind of inkling, or even if you don't have an inkling, to start off by kind of sort of saying, kind of by validating and sort of saying, living with psychosis, it can be a form of hell. It can be, you know, really kind of terrible, really, really awful. And many of the people who I work with, they sort of tell me that it kind of gets to the point for them where they can feel suicidal. And sometimes those feelings of suicidal, it can be a bit like this, and say something about it. But other people, they say it's a little bit like this. And the more, I think as well, if you're able to, without breaking confidentiality, if you're able to relate to the person that you have got an idea of different kinds of experiences that people have shared with you, and then you're able to share with them what those experiences are, that can open things up. And then just saying to somebody, so I was just wondering, what is it actually like for you? And one of the one of the fears that many participants have got is indeed that the therapist is not up to hearing about the suicide, their suicidal thoughts and feelings. So they want to protect the therapist in some way. So getting across right from the very beginning that you're not that kind of individual, that you do want to talk about suicidal experiences, and that is important. I think that is one of the top tips. The second thing is to encourage people to tell you then, well, what is it about their psychotic experiences? What again is happening? If they're telling you about the voices, sort of say, well, what was happening with their voice, with your voices? And again, to sort of clarify, to sort of say, well, is it one voices? Sometimes the people we work with, they don't just have one voice, they have a number of voices. I'm just wondering, what is happening for you? And if people sort of say things like, well, I can't tell you about the thoughts that are in my head, they're too dark, they're too difficult, then just sort of try to encourage the individual and sort of say, well, an awful lot of us do have very, very difficult and very, very dark thoughts and feelings. We don't always talk about it, but many of us do have those. So could you tell me a little bit about what's happening? So get it out in the open, get it expressed. Stop people, if at all possible, stop people from trying to kind of put any of that under the carpet, from trying to suppress what they're actually feeling.
Thank you for this. And we actually have two related questions about asking about suicide directly. One is, if you're seeing a person who is experiencing psychosis not face-to-face in a hospital setting where they are an inpatient, but during an online session, can you directly ask a question, do you have thoughts about suicide? And a related question to that, maybe you could comment on that as well. If we ask directly about suicide, wouldn't it just bring more obsessive thoughts about how to suicide?
Okay, so with both of those questions, so absolutely asking people about suicide online or in inpatient settings, or in any situation which is not necessarily face-to-face with the person sat there in front of you. Of course there are going to be challenges, and of course there are safeguarding issues, and certainly, of course, you've got to abide by the sort of safeguarding principles kind of set up by your NHS trust. But the basic principle remains, which is it's important to ask people about their suicidal experiences. Now, depending on what they tell you, but this also applies if you're working with somebody face-to-face with them right in front of you, depending on what they tell you, you may indeed need to sort of implement certain measures. So, for instance, if somebody says, no, I can't keep myself safe, I actually cannot keep myself safe, then you have to either take them to a hospital yourself or get an ambulance to them, or similar measures if you're in an inpatient environment. And certainly that does become more challenging when you're working online. However, one of the things that we learned through COVID, I mean, clouds and silver linings and all of that, one of the things that we learned through COVID was just how open participants were to therapy sessions that were not just done remotely via Zoom as we are today, but also by phone. And for many individuals that felt a lot less threatening, and so they were much better able to talk about their suicidal experiences. However, the same safeguarding procedures have to be kind of there. It just becomes slightly more difficult if you're talking to somebody remotely. So you've got to be sure that they are indeed in a place where if you phone for an ambulance, that the ambulance will get to them in that place. So logistically, it can be kind of more difficult, but the principles are indeed exactly the same. Now, in terms of rumination or kind of making suicidal thoughts and experiences more difficult, this is something that we really do not find, and if you talk to people, they will tell you that talking about suicide does not make suicidal experiences worse. It does not make the rumination worse. In fact, what does make rumination worse is not talking about it and leaving people sitting there with the suicidal experiences thinking, This is another person. I can't even talk to my therapist now about these thoughts and feelings. I really am stuck. Now, I really, really am stuck. If I can't talk to my therapist, now what do I do? Now where do I go? So it doesn't actually make those sorts of thoughts and feelings become more ruminative or more intrusive. They're there already. They are intruding and they are present. What it can do is start to allow you to talk to the individual about the sorts of things that they may have found helpful already. And this is something to also keep in mind, that the person is there in front of you. So chances are there will be something that you can find where someone has sort of said, well, actually, this tends to kind of really help. So it allows you to kind of do that.
Thanks for that. Thanks for clarifying it. And last question probably is a more challenging one, and you touched upon the participants sometimes not wanting to share their thoughts. So what if we have a person with paranoid features and says, my demon doesn't allow me to talk about things, and if I talk, something bad will happen to me or to others? How to approach such people?
Okay, so I think that kind of paranoia can be very difficult and can be very challenging. So one of the things I guess that we sort of learned from sort of talking to people directly about this kind of thing, first of all, it's kind of the evidence. So whether or not a demon, you may feel that the demon is going to make bad things happen, but has the demon actually done that so far? The other thing is to look at what may make the demon kind of quite quiet. So if you kind of talk about other things for a little while, or if you talk about things in a certain way, the demon perhaps doesn't get quite as angry or quite as intrusive. And so what, a little bit like with voices, quite often if you just sort of say, well, I'll just allow the voices to be. I'm not going to focus on them. I'm not going to not focus on them. I'm just going to let them be in a neutral state, a bit like a grumpy relative sitting on sitting in your living room over Christmas. You know they're grumpy. There's no point in talking to them. There's no point in not talking to them either. Just let them be and carry on with whatever's going on. If you just allow that to happen, quite often the demon, quite often the voices, they quieten down, they start to recede into the background. And as they recede into the background, that can then allow the individual to talk about their experiences. You can also encourage people to use metaphor to talk about their experiences. And depending on the individual, but something which some therapists have found quite useful, is to have people draw or kind of depict something kind of with crayons or with a pen or something. So rather than speak, to be able to express whatever is happening for them in a way which is not verbal. It's drawing. And for one individual who I can kind of remember, what they found very, very useful was to use kind of paints, not just because of kind of demons or voices, but because for them, they found it quite difficult to find the words anyway. And painting, it allowed them to get around that. Excuse me.
Thanks so much. And from all of us, we wanted to really thank you for answering this and bringing all these like clinical details so we can actually even touch how to things. And this is really important for us. So thank you, and we're glad we had you today. We also look forward to seeing all the listeners after the lunch break. Please have a good break, and we hope to see you and continue at 2:15.
Okay, thank you very much indeed. And I'll say goodbye. Bye-bye, bye-bye, bye-bye.
Thank you.